At the outset, I would like to thank Dr. Vijay sir and my friend Dr. Chandrasekhar sir to giving me this wonderful opportunity. As you all know, when any anterior segment case presentation, we write notes like this. But if you face abnormalities, anterior segment, you will not start with the slit lamp. You start with the phase, whether it is asymmetrical or the whole phase abnormalities you might miss if you go to the slit lamp first. So look for any, each of these can be a separate case for you. So whether it is ptosis, lid tumors, lag of thalamus, blepharophimosis, lid retraction, all this should be examined before going to the slit lamp. Or any phase abnormalities, the whole phase abnormalities should be seen, and whole eye like should be examined, like if microphthalmus, microcornea, all this before going to the slit lamp, please see. The lids, look for any abnormalities. I'll be talking only on the abnormalities, whether it is ectropion, entropion, symblepharon, make a note of it. And the discoloration of eyelashes will give you a clue that is scoliosis. Look for the adnexal swelling. If it is present, look for rhoplas and what kind of regurgitation is there, whether it is mucus, mucopurulent or watery. In the conjunctiva, whether it's clear or congested, you have to look for. If it is congestion, whether it is a conjunctival congestion or circumcorneal congestion, the difference between the two is the commonly asked exam question. The fornix, look for any follicles, and avert the upper eyelid and see for papillae. The other common exam question is the difference between the papillae and follicles. Follicles are seen in infectious conditions such as trachoma and your viral keratoconjunctivitis. Papillae is more in the allergic conjunctivitis. Other exam spotters will be conjunctival degeneration such as pterygium, nodule at the limbus. Look a sharp look at the nodule. If it is a dermoid, then look for preauricular tags so that you can be discussed on the golden hair syndrome. If there is a growth, you will be missing a OSSN, then you should be able to see the extent of the tumor and describe what the conjunctiva looks like. The sclera, look for any nodule, whether it can be a nodular episcleritis or scleritis, or a diffuse congestion as in scleritis, scleral thinning, necrotizing variety of scleritis. So the systemic association should be coming into your mind, or a scar with scleral thinning or staphyloma. In the staphyloma, you will be asked about various varieties of staphyloma. Cornea, when you describe cornea, take care you come in layers. In the epithelium, where there is a defect, ulceration, or epithelial bullae. Or in the stroma, if it's a diffuse stromal edema or a racemate folds. And in endothelium, you should look for guttata, or if there is any pigments or KPs. If cornea is clear, it's okay. If its cornea is having opacity, try to describe the opacity, whether it is a band-shaped keratopathy or a leucoma, whatever opacity is there, you will be asked about the different type of scars in the cornea. If the opacity is associated with vascularization, you will be asked about the deep vascularization and superficial vascularization. And if it is superficial vascularization, you will be asked about progressive and regressive pannus, and condition producing the opacity with vascularization, stromal keratitis or interstitial keratitis. The picture to the right is opacity in a congested eye. There is a ulcer over the opacity, so we should be thinking of atheromatous ulcer. So the discussion will be on atheromatous ulceration and the treatment. And other keratitis which can be kept in the exam will be ulcerative keratitis, which is microbial. It can be viral, fungal or bacterial. If the epithelium, you have to stain with the fluorescein, look for any forms, like if you have a dendritic form, we will be dealing with herpes simplex keratitis. And in an ulcer, describe the size, shape, margin, extent of the ulcer, whether it's associated with hypopyon. In the iris, look for abnormalities which should be sought is the coloboma. In progressive iris atrophy, you can have polychoria. In any trauma case, a D-shaped pupil and iridodialysis should be sought. And in the pupil, if you have any ectropia and UVA, that should be noted. If the iris is atrophic, you should know which type of iris atrophy is there, whether it is sectoral or diffuse. All iris atrophy, look for retroillumination, look for transillumination defects. In the patinus loss, you will have a muddy iris in chronic uveitis. And in other iris abnormality, which is frequently kept in exam, is new vessels over the iris. On to the right, there is glaring new vessels, but in the left, you can see it is a small filiform vessels in the pupillary border, which should not be missed even if it is subtle. And here the questions will be the condition causing, how will you differentiate a new vessel from an iris vessel. Any vessel which is seen on the iris is likely to be a new vessel because normal iris vessel is usually not seen. In the pupil, the morphological abnormalities can range from occlusio pupillae, seclusio pupillae, festoon pupil, or a chorectopia or persistent pupillary membrane. There can be a combination of seclusio and occlusio pupillae where the total annular synechiae will be present, and so that there will be seclusion and you will have a peripheral bowing of the iris resulting in peripheral anterior synechiae and pupillary block glaucoma. In case of uveitis, we have to see whether there is uveitis in a white eye or red eye. So you will see for circumcorneal congestion in the cornea, you see for the keratic precipitates. The keratic precipitates, you should be able to identify whether it is fine granulomatous or non-granulomatous keratic precipitates. You will be asked about the arch triangle and the aqueous convention currents, and the iris nodule should be sort of when you see any granulomatous capies. You should look for flare, and flare is graded by the visibility of iris from 1 to 4, and the cells also. If there are grade 4 cells, it's called a hypopyon. So hypopyon, how to differentiate a hypopyon and pseudo-hypopyon is a common exam question, and an inverse hypopyon will be a differential in a silicon-filled eye. Other things in the anterior chamber will be a hyphema. The questions asked here will be what are the causes of hyphema, and what is the 8-ball hyphema, and what are the complications. When will you get corneal blood staining or the glaucoma associated with hyphema. Lens status, describe the lens status, whether it's clear immature cataract, mature, hypermature, Morganian, or a subluxated lens, and whether there is associated pseudo-exfoliation and amount of dilatation of the pupil because of pseudo-exfoliation. If it is aphakia, you should mention about the iridodonosis. If it is pseudophakia, whether it is an ACIOL, PCIOL, or a subluxated or dislocated IOL should be mentioned. In a glaucoma case, in the conjunctiva, you look for a bleb, and the questions asked will be whether it's a filtering or a non-filtering bleb, how to identify them. In an narrow angle glaucoma, the difference between a surgical PI or a YAG PI is asked. And if it's a post-congestive attack, you have the Oakes triad with corneal edema, sector iris atrophy, and mid-dilated pupil and glaucoma flecken. If it is secondary glaucoma, look for new vessels. And then you should do a gonioscopy and grade the angle from 0 to 4 and see any abnormalities in that. And examining, you should document, do a color coding, any vascular edema in blue, and circles will denote the epithelial edema, scarring in black. If it is an ulcer, ulcer is depicted in green, infiltrate and hypopyon in yellow. If the edema in blue, cataract also is in green. So these will be the cases kept, bullous keratopathy. And if it is bilateral corneal opacity, you're dealing with dystrophy, will be asked whether the genetic predisposition and the differentiation between dystrophy and degeneration. Ulcer, I said, in this I want to mention whether you should corneal in any case, corneal ulcer. Ulcerative keratitis, you should think of a Moran's ulcer and systemic associations of PUK. Keratoconus, okay, sorry, time is up. Take home message, I want to look at examine the patient as a whole, check for corneal on all the, mention about the pupillary reaction, whether it's brisk, sluggish, or RAPD is present, draw a diagram with appropriate color coding. Thank you.